Hi, this is Andrew Gregory. I'm going to walk you through my instrument analysis on the Back Depression Inventory 2. So, proceeding to the first slide, what is the BDI-II? The BDI-II is an update to the original BDI that was developed back in the early 70s. It was one of the original measures used to determine whether somebody exhibited signs of depression and how severe those signs were. The BDI-II was developed in 1996 as an update to that original measure. The reason being so that it could more closely align to the DSM. The DSM identified that symptoms should be evaluated over the course of 2 weeks rather than 1 week, which the original BDI did. So the BDI-II asks the test taker to self-report the relevancy of an item on the test, and there are 21 items. It takes about 10 minutes to complete the test. The test taker chooses between a scale of 0 to 3 on how closely the item identifies with the way they feel. Proceeding to the next slide, how does a BDI-II work? Well, the 21 items reflect factors identified as related to the presence of depression in an individual. The cumulative score of the 21 items reflect the presence and severity of depression in the individual. And the construct measured is the idea that those who suffer from depression will exhibit signs of hopelessness, anxiety, insomnia, guilt, just to name a few. The cut score is about 20, with the score above 20 indicating those with at least moderate depression. I believe it's about 43 would indicate severe depression. So going to the next slide, why does the BDI-II work? It does have a strong level of convergent validity of 0.71 when compared with the Hamilton Psychiatric Rating Scale for Depression, the HRSD. And it is a measure of reliability that reported that 93% of those who took the test and then retook the test a week later scored identically. This indicates a strong level of reliability in the test. So some of the advantages of the BDI-II. The BDI-II is quick, effective, and reliable way to judge the symptoms of a test taker. It allows for greater mobility of the test user. The test can be used in a number of situations and environments because all that is needed to administer the test is the test itself and a writing utensil. It's interesting when you think about other cultures too. The person who's administering the test user, would be able to take this out into any number of situations and cultures where they may not necessarily have the infrastructure to allow these people to go to a medical complex to get this test done. It's very mobile and it's effective in that way. Potential issues with the BDI-II. The BDI-II is not a diagnostic tool. As the DSM states, none of these measures are truly diagnostic tools. That would come down to a convergence of different things. You would have to look at qualitative measures as well. The standardization sample consists of a disproportionate number of non-minority women. Basically, white women were the predominant person or type of person or demographic of people that were identified in the standardization sample. And because of that, you can't really rely upon that. It lowers the validity of the test. You can't really rely upon that sample to show that the test could be used in a number of other situations and cultures. The reliability of the test is questionable given the lack of data on the demographics of the test takers involved in its measures of consistency. And social desirability bias may impact the response items influenced by cultural nuance. And again, referring back to what I said just a moment ago, it's interesting because the mobility of the test is a huge positive, but the fact that they have yet to really provide a sample that consisted of a culturally diverse group of people to prove its reliability and validity, it's questionable whether or not you could carry over the results of this test into other cultures and or carry over the measure into other cultures and expect to get the same quality of results. Just looking at the test itself, one of the last questions that they ask about is sexual desire. And when you identify the nature of the question, it's interesting when you compare Western culture to other cultures and the way that we perceive sex. The question asks, what is your desire for sex? What is your desire for sex? What has your desire for sex been over the last 2 weeks? And in other cultures, it may not be that simple. There's a lot of different ways in which sex is used as a symbol of power. So the test may not that specific item on the test may not necessarily translate over into other cultures. Um, it's something to think about. Um, Final thoughts on the BDI-II. Differences in cultural understanding may dramatically impact the self-reported scores of the test items. And again, we kind of talked a little bit about how the self-reported aspect of the test does, it is a little bit concerning, because if somebody wanted to, fake their answers on the test, there could potentially be an issue. The BDI-II continues to be the most widely used assessment of depression in individuals throughout the world. And future iterations of the measure or other measures that seek to identify similar behaviors should attempt to normalize the differences in cultural characteristics. So going ahead, if there's going to be a BDI-III, or if there's going to be another test that comes out with another measure that's even more effective at trying to help lead to a diagnosis of depression, the items on that test need to be more conscious of the differences within Western cultures to Eastern cultures, more communitivistic cultures, for example. So I hope you enjoyed my presentation, and thank you.